am absolutely thrilled that David Goldhill is here. So this morning you heard some people talk who are experts in healthcare policy, and this is what they do and what they think about. And this afternoon you're going to be hearing about the healthcare system from practicing physicians, how it's affecting them. And Mr. Goldhill will bring to us a very unique position from our conference point of view of what this is like from somebody who employs people, who wants to help make sure he's got healthy employees and that those employees have coverage, and also from the point of view of someone who's been through the system and seen a lot of the faults with it. So Mr. Goldhill is president and CFO of the Game Show Network, not a small organization. And in addition to multiple magazine and newspaper articles, he's also written Catastrophic Care, How American Healthcare Killed My Father, and we are making books available for you. But his articles have been published in the New York Times, Wall Street Journal, Washington Post. He's got multiple media appearances. And one of my most favorite articles is the one I mentioned before, the Reason magazine article, which I will get you a link to. So I want to give him the maximum amount of time rather than spending a lot of my time introducing him, and let him speak for himself. So thank you so very much for being here. Greatly appreciate it.
Can you hear me in the back? Because I'd rather not use a mic. If I can avoid it, it's lunchtime. It's going to be hard enough for people to stay awake. Let me tell you why I'm interested in healthcare. In 2007, my dad had trouble breathing late one afternoon, or unfortunately it was late enough in the day that he didn't see his GP, walked into a hospital, and 24 hours later was dying from an infection he acquired there. He spent 5 weeks in the hospital suffering the after effects, including sepsis from that infection. And that was essentially...
You're going to have to use the mic. It's really hard to hear that.
Oh, is that right? I'm sorry.
Yeah.
All right.
Sorry.
Well, I can use the mic.
Thank you.
That essentially was my introduction to our healthcare system. And, you know, if you've ever lost a parent under any circumstances, it's a very difficult thing. It's an extraordinary amount of stress to go through something like a long hospital stay. And there's a lot of grief in losing someone so close to you, particularly seeing that sort of rapid decline from what had been health. My father walked into the hospital coming from work. I probably would have left it there, except a month after my dad died, the New Yorker published a piece by Atul Gawande in which he talked about there are 100,000 deaths a year estimated from hospital-acquired infections, and that many of them are now regarded as preventable. A series of protocols that had been adopted. All of you know about Atul's later book, The Checklist, that describes it in greater detail. And like a lot of Atul's work, it's very much about the culture of medicine. And what he was talking about was the efforts of a few doctors to get hospitals to adopt these protocols, how they were relatively low cost. But he was the doctors who were leading the effort were having trouble doing it. And that caused me to pause. Because I'm a businessman. And killing your customers is terrible for business. Ask any mobster. I had recently been running a movie theater chain, and we had a rule in this movie theater chain, which is if a soda spills and it's not cleaned up in 10 minutes, the manager of the chain gets penalized. Those of you in the room who are familiar with tort law may think it's because of liability, but it's not. It's because the business of movie theater chains is date night. It's young couples paying up for the babysitter, finally getting away from the screaming kids for a few hours at a reasonably priced date at the movies, Saturday night. Big part of our business. It's a special night. And if that young couple walks in and sees a soda stain, soda spill, something that feels out of place, they go to the movie theater across the street next Saturday night. That's it. That motivates us to clean up soda spills. And here I was reading about 100,000 preventable deaths, and the businessman in me said, hold on, something's wrong. How can you not possibly be incented to adopt low-cost protocols to save lives? Forget about policy. Forget about regulation. Just normal business incentive. Where is it? And so that started my work on healthcare. And most of what I write about is really what's the title of my talk today, which is the basic problem in healthcare that the system is serving the wrong customer? When my book came out, the New York Review of Books said, intending to be very kind, that never have the irrationalities of our healthcare system been so forcefully exposed. And I had to write a letter saying, no, you actually got it wrong. I appreciate the kind words, but my book is about how rational the healthcare system is. How, like every other industry we have, it rationally serves its economic incentives. Unfortunately, the economic incentives are the wrong ones, driven by the wrong customer. Now, that's a very strange idea in a field when we think everything major happens because of policy. And policy certainly has a lot to do with setting those incentives. I am not here to argue that there are any villains in healthcare. In fact, I'm going to argue the opposite. I'm going to argue that most of the people I have met since I've begun my interest in healthcare are motivated in great part by a desire to do good things for other people, almost everywhere you look. And it's one of the most confusing things about healthcare, is how can a system composed of people who are trying to do good things for other people and have that motivation far more than, let's say, in the cutthroat world of game shows, where that is not always our interest, how is it possible that the results are so terrible? How is it possible that you can kill 100,000 people from preventable infections and say, we've got to do better, as opposed to, we've got to stop that, which is what we do in every other industry. So it's a very hard concept for people to grasp. So let me give you what I think is the most obvious example. 1965 was a very big year in healthcare. As we all know, it was the year that Medicare and Medicaid were passed, and that the idea of insurance, health insurance, as the primary means of finance essentially became universalized. Not that everyone had it, but between all the policy incentives for employer-provided insurance, the resolution of the issue for seniors and poor through an insurance model, we essentially made that ideal at least universal in our system. Now, a lot of us think about health insurance the way we think about insurance, the way we think about auto insurance or homeowners insurance or other forms of casualty insurance. But there's one very important difference that was also institutionalized in 1965 that we don't think about enough, which is the insurer isn't merely financing the problem, the health problem that needs to be fixed. It's serving as the customer. The customer of our healthcare system, the person who writes the checks, are insurers, CMS, state Medicaid agencies. Why does that matter? Well, 1965 was also an important year in technology. It was the year that the first commercially available semicomputer was put on market. It was the PDP-8 by a company called DEC, which importantly no longer exists. And it went on the market for a retail price of $18,000, which was not a consumer product in 1965. $18,000 was a lot of money. But it was the first time somebody said, you know what? Maybe the market for computers isn't just going to be GM and the Defense Department and the biggest companies and bureaucracies on earth. Maybe just a normal company might use it to help manage their very large payroll. Maybe we can actually sell computers to somebody other than the truly few handful of customers you'd had up to that point. At $18,000, the PDP-8 was roughly 80 times what the average American spent on healthcare that year. 80x. Let's fast forward to today. Almost everybody here is carrying something not only more powerful than the PDP-8, more powerful than that room full of computers, which is what mainframes looked like in 1965. Most of you are either on this now or wishing you could somehow politely be on this now. Even I am pretending to show this as a prop while I'm checking my emails. The average cost of this product is, not this one, this is a pretty good one, but the average cost of a smartphone now is $250. We will spend $8,000 per person, I'm sorry, we will spend $10,000 per person on healthcare this year, which means from 1965 to 2015, a period of 50 years, we went from this thing being 80x healthcare to 1/40th healthcare. 3,200 times difference. And if you Google why healthcare has gotten so expensive, the number one reason, by far, is technology. You want to take another look at this before you make that statement? Technology. Really? Outside of healthcare, technology has made everything cheaper, easier, lower cost, greater value, enabling us to do things we never thought was possible. How come in healthcare, technology is associated with something very different? More complicated, harder to use, harder to figure out, harder to understand, and far more expensive. The argument I make is the difference in the two industries isn't the complicated one that and forgive me for saying so in a well-known think tank, that occupies so many of our experts for so much time. It's a fundamentally simple one. They're aiming at different customers. Starting in 1965, the computer industry said, how do I get more customers into the computer fold, until eventually they're selling one everywhere on earth, which is what they're doing now. The healthcare industry said, how do I satisfy the needs of my customers, which are insurers and government? And I think we can trace a lot of what happened to that fundamental decision. Now, we know that healthcare is completely different than any other industry, which is why everybody needs health insurance, right? I mean, you want to go to a healthcare conference, have everybody nod their head in agreement, say the following statement. Healthcare must be paid for insurance because 10% of the population uses, pick your number, 80, 75, 70, it's actually now down to 65% of the spending in every year. So to think it could be a consumer good is absurd. Spending is highly concentrated. There's no market. People don't voluntarily buy services. It's not like anything else. Except here's the problem with that argument. That statement includes the four words, in any given year. In any given year, 2/3 of healthcare spending is done by 10% of the population. Let's compare this to some other businesses. In any given year, 10% of the population buys 100% of the cars. In any year, 10% of the population buys 100% of the college educations, and a much smaller percent of Americans buy 100% of the medical educations. In any year, 10% of the population buys 100% of the weddings, 100% of the divorces, and 100% of the refrigerators that often go along with both. Sometimes when I have nothing else to say, I simply use the rest of my allotted time to go through all those other goods that 10% of the population buy 100% of them every year. What's the problem here? The problem here is we've confused two things, right? One is the emergencies we're trying to cover through the traditional form of insurance, your house burning down. And the other is the stuff we know is going to happen where we have to worry about time-shifting resources. I will have to buy a car. My furniture will wear out, et cetera, et cetera. In healthcare, we've confused the two. And it's led us to do something very weird, which is we are now insuring everybody against the certainty of getting ill. 100% of the population, almost 100%, it's really something in the 90s, but let's say 100 for argument's sake, will spend 1 year in that 10% or more, like cars, like weddings, like refrigerators. The spending patterns in healthcare are far more regular over a lifetime than we've been led to believe. And yet all policy focuses on is 1 year. But the magic of 1 year in healthcare is extraordinary. Everything we do in healthcare is about 1 year. Why, I have no idea. We all live till 80, and we all focus on that 1 year. But the reality is, now that all of us are going to get sick and die, it's a most recent discovery in the healthcare literature, we realize, and now that almost all sickness and death is heavily medicalized, if you start thinking about healthcare more normally, which is a lifetime worth of spending, the way you think of everything else, suddenly the insurance component gets smaller. You start thinking of, I need to protect people against congenital illnesses. I need to protect people against unexpected things, things that happen early in their lives, early in their careers. But other things are a little more predictable. Do I really need to protect people against getting old and sick? To the extent, if we do, if everybody's going to get old and sick. And let me explain why that whole protection thing matters. You see, there is no more expensive way to finance anything on earth than insurance. It's why outside of healthcare, nobody ever thinks of insurance to finance anything except catastrophe. It adds enormous administrative costs, it adds underwriting costs, it adds complexity. It adds 15, 20, 25% to any transaction you do. Anything you do. So we don't insure that you might have to buy a house. We just insure that that house burns down. Insurance is the most expensive way to pay for everything because it ruins the economic incentives and adds administrative complexity. So what have we decided to do? We've decided to insure everything, no matter how predictable. And what's the result? The result is we've created a system in which 100% of the population strangely believes that healthcare is only affordable with insurance. Where the other 100% that's supposed to pay for that insurance comes from, I have no idea. But this is the way we think. And so when I started thinking about healthcare, I started looking at our own employees at GSN. And I looked at, I took one as an example, a 24-year-old woman who was an entry-level professional for us. And I said, all right, let's look at her lifetime of contributions to the system and see what it is. And let's remember that one of the key elements of healthcare policy that keeps this whole system going is nobody ever gets to know how much they pay. Because you're never going to spend $3 trillion if we knew we're spending $3 trillion. Most of us think we're getting $3 trillion, not we're contributing into the system $3 trillion. So let's look at Becky. Let's assume a couple things about Becky. Let's assume she lives to 80. Let's assume she gets married at 30. And I actually think there's a pretty good chance she's going to. Lovely boyfriend. Let's say they have a couple of kids. And let's say that Becky's husband leaves her at 65. She didn't like that so much, but it really helps in terms of simplifying some of the financial assumptions. I'm not going to make her do it, obviously, but it helps figure out. So let's ask ourselves, how much is going to be put into the healthcare system by Becky? So the biggest thing Becky bears is the cost of employer-provided health insurance. We have a very good policy, as most companies in the entertainment industry do. And I looked at not just her share of the premiums, which is what Becky sees, but our share of the premiums, because they all come out of wages. I mean, I don't think there's any economist, left, right, any ideology who doesn't agree at this point that all of this comes out of wages, right? There's no company who says, you know, I got to pay an extra 15, 20%, but I'm not going to think about that. That's the price of employees. That's the price of labor. Let's look at the out-of-pocket she'll pay, the Medicare taxes she's paying. Let's look at the percent of her state taxes that go to Medicaid. And let's look at the percent of her federal income taxes that subsidize Medicare, because Medicare is not paid entirely out of Medicare taxes and premiums. Let's look at her paying premiums in Medicare starting when she's 65. So if the cost of health care goes up zero over the rest of Becky's life, literally zero, gross dollars, absolute dollars, you don't need to discount them, she will put in $1.2 million over the course of her life for herself and while her kids are dependents, her kids. If the rate of inflation in healthcare is just equal to what the administration provided with the Affordable Care Act as the initial estimates for 10 years, that number is $1.75 million. If she has a working spouse, it's $2.5 million. Now, there's two assumptions about Becky that are very important for this analysis. One is that Becky doesn't get rich, that she earns a nice, average, middle-class income growing by 3% a year. The second is that Becky never gets sick, or anyone in her family ever gets sick. So in other words, if you're putting 17% of your GDP into healthcare, anybody who's working is bearing something around 25% of their income and growing. That's quite a mountain for Becky to climb. But it's also a very tough thing for you to say to Becky if she knows that number, how do you feel about being protected by our insurance system? Because she says to herself, well, wait a minute. Am I going to put $1.5 million into this, $2 million into this as a middle-class family? Maybe all I want is to protect myself against that terrible thing that happens when I'm 40, or one of the kids being born sick, or having a series of illnesses that are so great that I couldn't financially manage it. Maybe I really don't need insurance to pay for, the broken bones. Maybe I don't need insurance to pay for the flu. In fact, maybe I'd rather pay for that myself. Because if you really look at what catastrophic insurance would cost for someone who put $1.5 million, $2 million into the system, it's a couple thousand, $3,000 a year. Becky's got the rest to spend on herself. Play around a little bit with the government's money. $1.1 trillion of spending on Medicare and Medicaid. That's $10,000 a year for 100 million people. If you gave them $10,000 a year per person, family of 4, that's $40,000. Do you really think you don't build a better healthcare system? Do you really think you don't have one which covers both the problem of catastrophe and insurance and builds a genuine competitive marketplace around most of the stuff we spend? This is the bill we got for the service of killing my father. It's okay. It's okay to laugh. There is no other way to deal with things like this. It's over $630,000. So it's, of course, monopoly money. Anybody here who knows anything about Medicare knows Medicare didn't pay it. But what's fascinating is going through the trouble of producing a bill that has no meaning at all. Right? So in the entire rest of the economy, prices are used to allocate resources. In healthcare, apparently they're used to play this weird game of monopoly. But none of these prices have any relationship to anything at all. Marginal costs, amount paid, division of services. It truly is like a random number generator. And my mother's share was $992, and I said, don't pay it, and she didn't. A couple things about this bill I want to point out. One is we got it a year after my dad died, and it was addressed to my dad. Which may suggest maybe CMS isn't as great in protecting his interests as they suggest. But the second is a more interesting one, which is if I had put my father at what was then the most expensive hotel in Manhattan, a Four Seasons, $1,000 a night, given him, an hour a day with physicians, round-the-clock nursing, room service, leased all the equipment you see in a typical hospital room and on the floor. In other words, if Dad had been the first Jewish king of Saudi Arabia, you laugh now. There's a lot of turmoil in the Middle East. No one knows how this is going to play out. I couldn't have gotten him more than $155,000. And the great thing is you get room service meals, which are better, and cable TV is free at the Four Seasons. When my son burst his appendix, my natural instinct was to discipline him, because it was yet another example of his carelessness and irresponsibility. His far more sympathetic mother said, let's bring him to the hospital, where they performed emergency surgery. And then we got this fantastic thing in which it said that it wasn't clear his surgery was necessary. And I have spoken to a few vets who did say that the alternative was to put him down. So strictly speaking, this may be right. But let's be serious about this for a sec, as hard as it is. And keep in mind, I'm their customer. I'm the CEO of the insured, right? We all know what this is, right? Our insurer makes us work unbelievably hard for the reimbursement, and yet my policy costs $17,000 for my family. This is the worst imaginable customer service there is, and one of the fascinating things about it, and I spend a lot of my time debating traditional healthcare experts, is that the argument is, when things are bad, you don't want to be the customer. You want to be protected. This is protection. I include this receipt from my dry cleaner in New York to make 2 points. One is, if you can avoid it, don't have your dry cleaning done in New York. It's unbelievably expensive. But the second, as it relates to healthcare, is look how detailed that bill is. When I started bringing my shirts in to be laundered in the 80s, you got a handwritten bill that said 10 shirts. They lost one, and they said I meant to write 9. Right? Then they got word processors, equivalent cash registers that spit out what looked like official looking mail that said 10 shirts, and they said, I meant to put in 9. Then they started saying things like 5 white shirts, 3 striped shirts, 2 blue shirts. Got harder for them to say, no, you only gave us 9. Now they do everything. They tell you about the shirt in such exact detail that you can almost manufacture it in front of them. Why? One cause, obviously, was the Dry Cleaning IT Act of 2004, which completely changed IT in the dry cleaning sector. The second is that dry cleaners, apparently unlike hospitals, employ very educated people who are capable of adjusting to IT. The third one, though, is the one I want you to think about, which is that dry cleaners compete. And when the guy across the street does it, you do it. In fact, that is how IT has developed everywhere. Why didn't we have IT in healthcare before we had a bill that said, you got to do it, and good news, we'll pay for it. But by the way, once we pay for it, you have to do it exactly the way we say. So many of you may know that famous RAND study that said, oh, if you do, if we had electronic health records and interoperability, we'd save $80 billion a year. And the fantastic thing is the cost is roughly $40 billion, and the good news is the government's spending that $40 billion. Now, most people said, no brainer, $40 billion for $80 billion. How could you not do that? Let me tell you what I said. I'm getting 1% at the bank on my money. You're telling me there's an $80 billion annual return on a $40 billion investment, and a $3 trillion industry won't make it? That makes sense to me. Something's on its face. If you went away from the island of healthcare and used the logic we use everywhere there, somebody would have said, no, wait. You need to make investments where there is no benefit as a government. If there's a 200% annual return, there's trillions of dollars of private money chasing, 4 or 5% returns. How is it possible? Well, I'll tell you how it's possible. There is no $80 billion in savings that anybody can monetize. It tells you all you need to know about the incentives. Think about a healthcare business that made more money by being cheaper, like Walmart, by being more efficient, like everybody, by saving money, by reducing deaths. None of those contribute to your business model. At the end of the day, no matter what the policymakers think, healthcare is a cost-plus business. As long as they can show costs going up, they can justify higher reimbursement. And I'll come back to that in just a sec. And so what you have is a complete misunderstanding of how IT gets adopted, and a complete misunderstanding of why healthcare is behind auto mechanics and its use of electronic records, and a complete misunderstanding of how to get there. So this is what we've done in healthcare. We've said everybody has to buy servers, everybody's got to buy handhelds, everybody's got to do this, and everybody's got to follow. This is not what the meaningful use rules actually look like. They're actually not stacked page by page. But you get the point. These are the instructions to an iPad. There aren't any, which is why a 4-year-old can use it. It was designed that way. And unfortunately, in the rest of the economy, what we discovered is IT that works evolves slowly, but then quickly, because it matters to the customer and gives you a business advantage, or your competitor has a business advantage you must catch up with. I'm going to skip this because I'm going a little long, although it's fun, but whatever. It's in the book, I think. let's talk about what our smartest minds are thinking about in terms of healthcare reform. We can't conceive that letting a market operate in healthcare can drive what it does everywhere else, which is incentives to value, cost control, efficiency, safety, and service. We're stuck on the idea that centralized customers have more power and therefore more leverage to do good. And so what the smart minds want to do is figure out what's the right way to pay for healthcare that will do all the stuff that a market does and everything else. And so payment reform is now in its 30th year, maybe longer, of being the solution of the smartest minds to solving the problem. Using insurers, mostly CMS, to some extent state Medicaid agencies, to drive change. So let's look at the most successful payment reform we've seen in this country, the prospective payment system I think many of you are aware of. Up to that point, hospitals had a complete incentive to keep you in the hospital as long as possible. They were basically in the hotel business. And still are, but they were really in the hotel business. And so along came a Reagan administration reform that said, tell you what, we're going to just pay you for the, essentially, and most of you know this, for the diagnosis. So keep the patient as long or as little as you want, but we're paying you one fixed amount. And the theory was, and there's some other theories as well about integrating care and coordination among physicians, but one of the big theories was you'd no longer have an incentive to keep people in the hospital. And it is extraordinarily successful in that sense. You can see the declines in the number of nights per Medicare patient, the total number, absolutely an extraordinary result between 1983 and today. I measured this last year, so 1983 and last year. And if these were hotels, we know what would have happened. Prices would have collapsed, right? The number of hotels would have gone out of business would have been enormous. Hotel rooms would have shrunk everywhere. And hotels would be desperately competing for customers. And so, of course, that's what these declines did to hospitals as well. Well, maybe not. The amount Medicare reimburses per night of stay in a hospital is up 5x, even though they don't reimburse per night. But the effective reimbursement per night is up 5x. So imagine that. Hotel business in your town declines by 50%. Hotels raise their prices 5x. Sound possible? Here's the better part. Hospitals say their costs have gone up 7.5x. So that Medicare's getting even a better deal now than it used to before, because before Medicare was paying 50% of their costs, now they're paying only 25% of its costs. What does it mean? What it means is, one of the mistakes we make in healthcare is looking for the right way to do things. And if we can find it, we're done. Prospective payment system worked. It did exactly what it was supposed to do. But so did the hospital industry. You're running a hospital, you're not sitting there saying, well, we're down 50%, we're done. You still have to go to work every day. And so what do? You say, all right, this is the new reality. How do I adjust to the new reality? See, here's how they adjust it. They push their costs through the roof. You want to know where high-tech medicine comes from? This is where high-tech medicine comes from. That's the right response. How do I convince my paymasters that it costs more, ever more, to manage a patient now that I can't be in the hotel business? Now, we hate thinking like that, right? Because it happens gradually. But every payment reform is like fixing a broken watch by just changing the time. It's only right for the moment. The way the real world works is it's endlessly dynamic, right? You make a change, a reform, you need another one a year later because the industry will adjust to this new incentives, and it won't be an arrow. It's never an arrow. If you're running one of these institutions, I am a businessman, I can tell you this. Our world changes daily. That's our job. How do we deal with the new reality today? The idea that there's some perfect way to pay for healthcare that's going to change all this is in itself the most damaging idea in healthcare. And outside of healthcare, what we say is we need dynamism. We need feedback loops. I don't know what the right IT is for my industry 5 years from now. I know what it is today, and I know I'm going to respond to all the changes between now and then. It's true of prices. It's true of products. It's true of everything. And what's fantastic is you look around the rest of the world we live in. is that we see diversity and choice as the key to competition and value. And in healthcare, we've got smart people saying, what's the one way to do this? As if no one's going to respond. I want to say a word about Medicare. Because in the introduction, I mentioned the reason piece, which I wrote as a review of Gawande's new book on being mortal, and how looking at the culture of medicine missed the real story of end-of-life care and Medicare generally. I have a very critical view of Medicare, right? I think it's been very bad for seniors in ways that they don't understand. Specifically, what does Medicare say? And this is, by the way, unique in our single-payer system. Most other single-payer systems don't say this. We will pay for any care a senior needs. So forget it's health care for a minute. Let's say it's the game show world. And imagine the government saying, we will fund any game show America needs. What's my incentive as a businessman? To expand that need. That's it. I no longer need to come up with value. I no longer need to come up with results. I just need to increase need. Now, I know it's very harsh for people to think about economic incentives driving things because, as I said, lots of good people, lots of caring people. But let's look at what seniors are dealing with today. We have an extraordinary amount of seniors on very large numbers of prescription drugs, and studies showing that somewhere between 25% and half of them are taking drugs that are counterindicated with each other. But there's no coordinator, right? Gerontologists have been driven out of business. If gerontology was a stock in 1965 and you knew Medicare was going to grow to be $550 billion a year, you would have bought that stock and you would have lost a ton of money. Because what drives Medicare's economy isn't what's good for seniors, it's how Medicare chooses to reimburse. They reimburse procedures, specialists, treatments. Primary care, not so much. And so they've been driven out of business. The accidental admission death rate of seniors into our hospitals now exceeds the combat death rate in Iraq. That is an incredibly ugly statistic that in front of most audiences I don't mention because it is so painful to think about. You're a senior, you get admitted to a hospital, your chances of dying from an accident are greater than a soldier in combat during the recent Iraqi war. But let me give you one last summary number, which is in 1965, the average senior, when roughly 3/4 to 80% of them paid for all their health care out of pocket, spent somewhere between 10 and 11% of his or her income on health care. That was the problem we tried to solve with Medicare. Fast forward to today, 95% of all dollars spent on senior care are spent by the government. The 5% that seniors spend out of pocket is now equal to 17% of their income. These things happen slowly and gradually. But if you told a senior in 1965, we're going to increase the share of your income spent on health care from 10 to 17%, we wouldn't have Medicare. And I'm not sure how much they can take. I want to make a couple points and end on a positive note because I'm actually very optimistic for reasons I want to get to. Here's the most important one. We endlessly in healthcare debate things that were debated in the 20s, 30s, and 40s without embarrassment. It's amazing to me. You know, I was in a debate the other day with someone who said that the British got it right in 1948, and I asked him whether anybody else had gotten anything right in 1948 in terms of what we believe today. Any other business, any other industry got it right in 1948. Why do we believe that this solution to the most dynamic industry on earth could possibly last 60 some odd years? In itself, doesn't that seem incredible? Here's what we've missed about healthcare. While we've been arguing about insurance and built the state system and all the rest, healthcare itself fundamentally changed. It's gone from what it was, which was rare, urgent, major, to considered. Remember, the argument for having insurers be your provider, be your buyer, was that who wants to go shopping for a surgeon when you're just had a heart attack? Or when you've suddenly got a cancer diagnosis? Or when you're hit by a bus? Well, people get hit by few buses anymore. And very, very few cancers now have, I got to get you on the table tomorrow. The overwhelming bulk of healthcare spending, overwhelming, we think it's somewhere in the 80% range, maybe more, is about a considered decision the patient has to make. Cancer care is almost always given with, here are your alternatives. It's not that you can't be the customer. You have no choice but to make the choice as the patient, right? Significant percent of all treatment now is chronic care, which, as you know, is a balance of lifestyle decisions and treatment considerations. Even most of the stuff hospitals do are scheduled surgeries, knee replacements, hip replacements, what have you. And yet, we still act as if everybody who needs health care is having an emergency. We've missed the reality that the relationship between doctor and patient has gone from the, you have to do it and you have to do it now, to, let's discuss your options. So we've built a system in which there is no consumer, where we now have to make the most important choices of our life without the information and accountability we have in everything else. So with all of this, why am I optimistic? I'm optimistic because the customer is rapidly changing in healthcare, accidentally, but importantly. We think roughly 25%, maybe 30% of employed Americans have what were a few years ago considered high deductible plans, and a meaningful number of them have health savings accounts. We expect that number to go up to 50% or higher in the next few years as the Cadillac tax is introduced. About a third of employers say they will move to solely high deductible plans in response to the Cadillac tax. One of the biggest surprises of the exchanges has been that people have preferred low premiums to low deductibles. In fact, a lot of you have seen data saying, hey, it's strange, premiums have gone up much at all. But deductibles have gone through the roof on the exchanges, and that's a choice people have made. Whatever you think about it as policy, whether it's good or bad, here's the fact. We're probably 4 or 5 years away from the average privately insured American family paying 100% of their health bills every year out of pocket. Because remember that unusual distribution of spending. If you've got $2,000, $3,000, $4,000 a year of bills, chances are you're going to be paying for all of it. And suddenly, the customer for most low-level health care in America is going to change. Why is that good? Well, a lot of people imagine that healthcare requires this absolute regulator, unlike anything else, to assure quality. And the argument I make all the time is, what quality do you think is being assured? Well, you know, all the time when I talk about a consumer-driven healthcare system, people say, well, how would you make sure people were safe? And I always say, how do we do it now? We don't. And in fact, one of the problems we have now, if you spend a lot of time looking at how CMS works, which I do, is that the sheriff, this is their idea of the sheriff, is somehow he's like Clint Eastwood and Dirty Harry, is the partner of the criminals. The hospital system is so closely tied to CMS, and I know this as a member of the board of Leapfrog, that you have to remember that the reason there's a 1 or 2% penalty for killing a patient, which, by the way, has had a beneficial impact, better than a 0% penalty, but significantly less than the 100% penalty that a consumer would insist on for killing a loved one. But the reason it has to be 1 or 2% is CMS says, if I ding you more than 2%, I got to pay you more somewhere else, because I can't have hospitals going out of business. I'm their partner. The sheriff that we imagine we have is their partner. The real sheriff is probably more like Cleveland Little in Blazing Saddles, and if you haven't seen Blazing Saddles, you're not an educated person. There's nothing I can do for you. You know, not a lot of resources, not a lot of leverage, just improvisation, playing it by ear, evolving, the way everything else does. Kenneth Arrow very famously said, 51 years ago, you can never have a normal market in healthcare because consumers will do whatever doctors tell them to do. They're desperate. They're afraid. They have no ability to act rationally. So Kenneth Arrow has a Nobel Prize and I don't, but I think there's at least 2, maybe 3 things he got wrong. One is that got worse when you weren't paying for it. The chances of the doctor trying to sell you more stuff got worse. And let's face it, there is an absolute consensus that at least a third of treatments in this country are unnecessary, and unnecessary is always bad for the patient. Always, every time. The second thing he got wrong is he couldn't see the future. Where healthcare went from being that rare thing where you have cancer, I got to get you on the table tomorrow, no time to talk about it, let's talk about your options, where you had to be the decision maker. We need a consumer infrastructure to help the patient be that decision maker. And the third thing he got wrong is something that a lot of people still get wrong, which is that consumers don't do anything, ever. Steve Brill and I did a debate in which Steve literally said, you know, when I had my heart attack, I didn't want to shop around. And I said to him, when I had my tire blowout on the highway, I didn't want to shop around. I got a better value than you did because there's a market for tires. And even that guy saving me from 75, 80 mile an hour traffic on a highway. And by the way, trust me, your lack of support for speed limits goes away when you had a tire blowout on a highway. You say to yourself, why do they let people drive faster than 30? I have no idea. But that guy doesn't come to you and ask for your insurance and your net worth statement. He's going to overcharge you, but only by so much. The way consumer economies work isn't that we shop. Some of us shop for entertainment. Some of us shop because we're desperate. Some of us shop because there are a few things we're really interested in. Cars, perfumes, fashion, what have you. But the way the consumer economy works isn't that an angry mob marches on Neiman Marcus, says, we demand lower prices, and they change their name to Walmart. What happens is Sam Walton wakes up and says, I got it. I know how to make my billion. Lowest prices, all times, massive investment in inventory control. Giant stores. It'll cost me a fortune. I'll have margins of 2%, but everyone and I'll have to spend $3 or $4 billion a year telling people. But everyone's going to know I'm the low price leader all the time. What we want is the opportunity for the things we see everywhere else that drive competition on price, competition on value, competition on service, convenience, accessibility, ease, to infect healthcare. And the reason it hasn't happened is because there hasn't been a customer. No entrepreneur makes money except through lobbying, selling anything to the government. And selling to insurers is just as hard. They're interested in complexity, opaqueness, making things difficult. That's how they make their money. That's their business model. We are the ones, and I know I'm talking to a lot of medical professionals here, but all of us are consumers. We are the ones who care about low prices, high quality, safety, and then that most important therapeutic technique, convenience, ease of use, customer service. And those will be driven only by entrepreneurs. And the good news is, for the first time in an unbelievably long time in American healthcare and in some other countries around the world, entrepreneurs are saying, I can create the Amazon of healthcare, the Mint of healthcare, the TripAdvisor of healthcare, the Uber of healthcare. They're working on it, and it will be transformative. In the meantime, I think what we can do is something fairly subtle, which is to mentally get off the island of healthcare. Which means two things. One is, let's stop assuming healthcare is so absolutely unique from everything else on earth that it deserves its own island with its own laws, and gravity doesn't apply, and all the stuff we know about everything else doesn't mean anything. And the second is, let's take advantage of something we have, which is 310 million stories about healthcare. What I like to call the little picture of healthcare. All of us, every single one of us has a story about lost records and long waiting times and confusion in testing and being sent to the wrong specialist, being unable to get an appointment, all the way up to unnecessary surgery and accidental death. Let's take the little picture, not just these big picture policy arguments, and apply it to what could be the most dynamic and ultimately the most important contributor to human happiness of any industry we have. Thanks very much for the time today.
That was great. Thank you.
Thank you.
And let's have some time for some questions. I do want to give time for him to sign books, but
would you suggest we take in terms of interacting with our patients to try and encourage this kind of doctor-patient focus on care as opposed to the industrial?
So I'm going to approach that less from a doctor and more from a customer, which is,
sure.
I suspect as more people like me have high deductible plans, we're just going to expect a different consumer-facing experience when we go see a doctor, whether in a private practice or a clinic or what have you. We're starting to see, I mean, this would have been the real drive for electronic records, right, which is you're never going to get patients to spend their own money for little pieces of paper you keep. I would suspect future doctors here, whether they like it or not, are going to face customers who are going to say, that doesn't work for me. And what I would encourage is to be proactive. I've been in a whole bunch of industries that have been transformed seemingly by technology, but really by a consumer having a different opportunity to see value, right? And I think we've always got to remember that. You know, in healthcare, unfortunately, in great part because so many people are trying to do so many good things, there's a lot of expectation in the healthcare industries that things should stay the same. There's something wrong if things change. And things are going to change. And so what I've seen in other industries, and I know a lot of people in healthcare hate thinking about healthcare as an industry, has been that you either adjust or even better innovate, or you fall behind. Now, obviously, doctors in private practice are at great risk right now for a number of factors that are changing. Right? One is that a lot of legislation has encouraged hospital consolidation, hospital power. The nature of the hospital-insurer relationship has encouraged that as well. Private practices in many places are being forced to sell out. Clinics are being forced to sell out, essentially becoming rainmakers for hospitals. But everything changes. That's not going to be a great experience for patients. And as long as people are creating alternatives, and I think we're going to start seeing alternatives with, you know, both concierge care for the wealthy and middle-class membership services, you're going to see a whole lot of different service models that I think put pressure on non-competitive leverage-based models. And so I think if you're an individual physician, thinking about your work, and I meant what I said about the value of service, right? I mean, the fact is, dealing, you know, as a non-medical person, and the one member of my family who didn't become a doctor because the sight of blood makes me crazy, and the needle turns my stomach, and I thought I'd be better as a businessman. Dealing with the healthcare system is anxiety-causing for patients. But by the way, a lot of industries are. And so how you create an experience that makes the little stuff, the administrative stuff, the meaningless stuff, the waiting rooms, less stressful, I think is going to determine who wins. I think you're going to see whole extraordinarily different forms of service models. I think you're already starting to see it. So, look, I've been through this with my friends who are lawyers. There's a type of professional who just, you know, rails against windmills and says, that's not the way my father or mother had to practice medicine. I don't know why I should have to. And there's another who says, you know what? If it's good for the patient/customer, then it's good for healthcare. And I'm going to be part of it. Anything else? Want to talk game shows?
The stuff you said about innovation, I think is really exciting and exactly what we need to do, but how do we get there? I mean, in the system that's so, you know, regulated and everything, is it just, you know, in pockets to, you know, find where it can thrive and try to encourage that, or?
So I think the right answer to that, I'm going to speculate, is the shipping container. So the shipping container is the most transformative piece of technology, arguably in the 20th century, right? And everybody, in an industry that was very highly regulated and government controlled, and everybody was opposed to it. And if you know the story of the shipping container, right, for the entire history of mankind, the cost of trade has been a ship. And so you wanted to load it as efficiently as possible, and we had ports and longshoremen and everything. All they did was figure out the optimal way to load a ship. And then a guy came along and said, you know what the best way to load a ship is? Air. Just put everything in a standardized box. So what, the box will be mostly empty. Put the, you know, every ship can be built to a standard. Every port can be built to a standard. And you can take the box, you can put it on a train, you can put it on a truck. You don't need to unload it. Destroyed almost all of the traditional jobs in shipping. Destroyed port cities. Destroyed unions. right? The estimated value of the shipping containers brought to the world economy is in the tens of trillions. And it's enabled things that we would have thought was impossible, such as taking something this size and assembling it in 10 different countries. And the cost of shipping is almost zero because of the shipping container. What's interesting, and I always use the shipping container because I want you to think about some guy saying, here's what we're going to do. We're going to put everything in a box. Well, that's the most inefficient use of a ship imaginable if you're thinking the old way. And he had no friends, but he had the right customer. Right? The customers were the big manufacturing firms who just couldn't afford the massive amount of inventory they were financing. That was it. And it was just having the right customer that means that every old-fashioned port doesn't exist, and that there are cities around the world that have 10 million people in it that didn't exist before the shipping container. And when I think about healthcare, I had a conversation at this event in New York to get all the New York healthcare leaders together to talk about healthcare, and I was going on and on about how healthcare providers have no incentive to save costs. And the head of one of our biggest hospitals started yelling at me saying, we have such a strong incentive to save costs that just last week, we had a meeting of the hospital administrators, the doctors groups, nurses groups, drug companies, device providers, insurers, everybody in healthcare sit around and talk about how to reduce costs. And I said, let me get this straight. Is there any cost that isn't one of your revenues of the people in that room? I mean, isn't that like inviting turkeys to come up with a menu for Thanksgiving? I'm not talking about whether you'd like to reduce costs, whether it doesn't sound theoretically good, but your incentive, right? Discounters have an incentive to reduce costs by getting more customers. That's it. And when we think about what a competitive healthcare world looks like, for families that are now paying out of pocket, somebody in your town is going to say, I know you can't afford healthcare. I'm building a clinic that will undercut anybody in price. It's your money. And so to some extent what I'm saying is once things like that start happening, I think they happen fairly quickly. Because we've seen it in so many other industries, right? All of you know the example of Uber. Taxis are regulated every single place in this country. They're regulated to protect taxi drivers. And Uber's winning. Because they've got customers. And I think that's why I so emphasize, policy. I know I'm in Washington, but I'm trying to be here only for a few hours. Policy is very backwards looking, no matter how hard people try. But waking up every morning and saying, oh my God, how am I going to make a living in a new world? That's very forward looking, and it's an incredibly dynamic incentive. And I think we're about to see that in healthcare in a way we haven't seen it before. Again, it's not going to solve every problem. Obviously, major illnesses are still going to be resolved by hospitals, which have no economies of scale and scope, and fewer and fewer competitors as this administration's policies roll forward. But that can change. IBM had very few competitors in the 80s. So I think the answer is things happen slowly and then fast.
So if you're not,
I have a question. If some of the free market reform that we're talking about does move forward, I'm curious as to who and maybe what their incentive would be to provide like the safety net for maybe the disabled or the poor in our country.
Yeah.
And, what would drive them?
So I know I'm at Heritage, but I'm not. I happen to be a liberal Democrat. And when I talk about, I'm not talking about free market reforms. I'm talking about using markets that exist in everything. But right now in healthcare are constrained by very strange incentives that produce absolute perverse outcomes. I believe in a safety net. I believe in a universal safety net. Many people don't. I'd love to have that debate. But I actually think the only way to have a universal safety net that works is to define it correctly, which is we're trying to protect people against catastrophe that can't protect themselves, either because of income or because these are things that are so rare and so major or so occur at too early a point in life. To me, the fact that we've spent 17% of GDP on healthcare, and that so much of it is waste, and so much is administration, and so much is excess, and it's so confusing, and so poorly delivered, and so unsafe, tells me that we're reducing overall human welfare, meaningfully, right? When the Affordable Care Act was passed, even though I'm a Democrat and voted for this president, I wrote a piece for Huffington in which I said, okay, we're going to spend $200 billion more on healthcare. I challenge any liberal Democrat to find a less productive use of $200 billion in the middle of the recession that won't help our target population more. So forget whether I'm not talking to the folks who don't believe we should spend money on people. They've got their views, that's fine. But those of us who do believe in using central resources to improve welfare, find me a worse use of $200 billion than more incentive to do more healthcare. Because let's face it, most of the things we're concerned about in healthcare, which is chronic conditions, are the result of, you want to look at what are the contributors to chronic conditions. It's income, education, anxieties related to family life and safety. You have to get to like 9th or 10th place before healthcare matters. So why do we spend the money on 9th and 10th place all the time? I meant what I said about the $10,000 per person forever. I'd rather do that. I think we'd have a better system. So I've got to be clear, this is not a right-winger saying, I don't trust the government to do anything. This is somebody saying, we've been through 50 years of the government trying to do everything. And I don't just mean in the US. The idea of both universal and comprehensive care is under pressure everywhere. Our system is so horrific, we don't notice. We don't notice things like the Berwick report on the UK, which said, we have a massive quality problem and a huge cover-up problem because of the nature of bureaucratic management of healthcare. It's a problem everywhere. We're ahead in discovering these problems, but everyone's going to get there. Healthcare has changed and our assumptions are in the 20s, previous 20s. Anything else?
One more question. What has the reception been on the Hill to your proposals? Have you had a chance to interact with any politicians?
Which Hill would that be?
Capitol Hill.
I think the greatest legacy of the Affordable Care Act, unfortunately, is that for 5 or 6 or 7 years it has sucked all the air out of the conversation about healthcare. And so the most interesting, the reason I don't do talking head stuff on television is I cannot argue that the Affordable Care Act is the second coming or the apocalypse. And those are the only two permitted positions. It is unfortunately so politicized, so partisan, that having serious discussions about healthcare is a very small group of people. The good news is, at some point, we're going to get bored. I suspect the Affordable Care Act is going to do relatively little, except, great news is insurance rates are back to 1999. If I remember right, in 1999, we thought we had a terrible healthcare system. So, at some point, we'll start to have a conversation about healthcare again. And I hope that having gone through a lot of these sort of great interventionist ideas and finding out they're producing very little value, we can start thinking more broadly. I will tell you, though, I'm less interested in policy than I am in what people do. And I think if you look at what's actually happening in the healthcare industries, you're seeing something different. Some of it, like always, is response to political pressure, and these are all political, hospitals are often the biggest employers in most states. It's a lot about politics. But there's a lot that's not about politics. And I think that's really interesting. I'll give you one very big example, and then I know I've gone on a little long. The growth of healthcare spending around the world. One of the great things I have is I don't know anything about health or healthcare. Right? I'm not a doctor. I find the whole subject incredibly painful to think about. So I don't have to think about health. I just think about products and industries. And the growth of healthcare spending coincided with the growth of chronic conditions. Right? It's all about managing people's conditions. That's what everybody is spending the fat pound of it, right? Incredibly expensive, incredibly low value, incredibly low return, but the best we can do. It looks like technologically we're about to enter an age of cures and personalized cures. So how are you going to run a centrally bought, comprehensive, universal, insurance-based system to deliver personalized cures? You can't. You just can't do it. And it's very similar to that moment where we went from Model Ts to, oh my God, we need 40, 50, 60 different types of cars to satisfy all individual demand. I think the healthcare system is going to fracture, not because the policies are bad. Of course they're bad, right? Not because we can't afford it. We print money and people will take it everywhere. But for the very simple reason that it won't work, right? It was perfectly designed for a certain type of care, which was the best we could do at the time. And I can tell you from my own experience, like I am 50% opted out of our healthcare system. Half of the physicians we use in our family don't take insurance, don't take Medicare, don't take Medicaid, and don't charge me fee-for-service. They charge me some other way, right? That is only going to grow. And as it grows, suddenly the possibilities for not just different types of business, but different types of actual treatment, care, concern for the patient, grow with it. I made this joke, and I'll end with this, when I was at some conference once where somebody said, what do you do about Medicare? It's an unsolvable problem politically. I said, don't solve it, right? Let it go on until seniors beg to get out. Because at some point, people like me, I'm not willing to let my mother see doctors who take Medicare. It's a huge fight, right? I want her to find doctors who don't. So at some point, if enough of us opt out, because most of us, let's face it, are not really urgently ill all the time. We have the ability to opt out and think differently about a lifetime of healthcare planning. Suddenly you've got different models out there. And one of the things we find from Uber is you got a different model out there, suddenly people just stop taking cabs. Even though the government regulates the rates, they just stop taking cabs. They really stop using landlines. They stop getting broadcast TV. It's okay that the post office doesn't deliver our email. It's fine. We get over it. Anyway, I know I've run on a bit. I don't want to take it.